Hello, I'm Dr. Preston Foster. I'm the surgical director of the liver transplant program here at the Methodist and Specialty Transplant Hospital. I'm here to talk to you today about consideration of a specific type of donors that we use in liver transplantation. Um, you've already probably received some education concerning the process of being evaluated for transplantation and some of the aspects of the care monitoring before the transplant, the perioperative transplant care, and of course your lifelong care with our transplant program once you receive a liver organ for transplantation. Um, um, Let me preface these comments in the sense that we only recommend the use of organs that we think will give you excellent function and a long period of function with the least number of complications. In liver transplantation, there is probably no perfect liver donor organ, but there's always some small issues about the liver function. But the vast majority, about 98% of the organs, work great for the patient's lifelong. Um, but I'd like to talk to you about these more complicated decisions that we make in the use of organs that mostly need your consent prior to transplantation and also to uh, be consented based on requirements of the United Network for Organ Sharing, or UNOS, so that you can already acknowledge before the donor becomes available that you have consented to these particular types of donors. The type of donors we'll talk about is, I'll list them for you. There's hepatitis B core positive donors. There are patients that already have hepatitis C and can receive donor organs where the donor is hepatitis C antibody positive, and I'll discuss that further. The use of fatty livers. Fatty livers do not preserve quite as well, but under the appropriate circumstances in the appropriate patient, they can be used easily. The other is what's called donation after cardiac death donation. Most of the organs are transplanted from people that have already been pronounced dead. Their heart is still beating, and would remove the organs with immediate preservation, while donation after cardiac death just means the heart is already stopped and there is some injury going on to the liver until they are pronounced dead based on their heart stopped beating for a particular period of time. And then the other is what they call so-called high-risk donors. All of our donors are checked very carefully for transmission of diseases, specifically HIV, hepatitis B, and hepatitis C, but the tests have limits, especially in patients that are possibly high risk for a recent infection of these particular viruses. So first, let me discuss with you hepatitis B core positive donors. Basically, I'll give you a little bit of kind of virology or clinical virology related to hepatitis B. Hepatitis B is a very common virus that actually causes liver disease. Probably 96% of the people that are exposed to hepatitis B, they develop antibody, and they basically can't be reinfected lifelong. Kind of like having the chicken pox. You are now immune to having chicken pox again, for the most part. There is a small group, probably 2% of the people that are exposed to hepatitis B here in the United States. They don't really get rid of the virus, and the virus keeps making copies of itself and slowly causes liver damage. And it's also one of the reasons that we transplant people is for hepatitis B infection. There is a middle ground. These are the patients that have a blood test that is hepatitis B core positive. And this antibody basically tells us that there is a small amount of the virus within the liver of a person. Those people live lifelong without any difficulties. There's no liver disease. Their liver biopsies are normal. Their liver function is normal. But when you take that liver from a donor and put it into a patient under immunosuppression, the virus starts making copies of itself. This tiny amount of virus within the liver starts making copies of itself and can cause liver disease. And so in the late 80s, we stopped using those organs for the most part because we didn't want to transplant some new disease that we couldn't control. But in the early 90s, medications become available, and actually a lot more different kinds of medications since that time you can be given, and it will stop the virus from making copies of itself. And with this, we again started transplanting these organs, knowing that they had to take one of these anti-hepatitis B virus drugs for the rest of their life. As long as this extra drug is taken, the virus will make copies and there will not be any liver disease. There's been a couple of patients that I've had in the last 20 years, 25 years, that the virus started making copies, but they basically stopped taking the medication. We figured this out and then restarted them on the medication. So from our standpoint, it's a no-brainer for the transplant surgeons or hepatologists. This will increase your chances of being transplanted with these types of organs, but you need to be signed up ahead of time, and you will be put on this special extra list. You'll be on the regular transplant list, but this will give you extra chances at these specific type of donors. Again, only probably about 3 to 4% of the population in the United States has this situation, and therefore probably 3 to 4% of the donors have this situation. We would like for you to sign up for this consent and beforehand. If you don't sign up now, we'll assume at that point that you are not interested in this type of donor, but you can take the consent home and sign up for it through a variety of ways. The medications afterwards have very little side effects and have been taken for, again, now for over a decade and sometimes 2 decades. The insurer almost always pays for this. I'm not sure we can guarantee that, but almost every case that I've been dealt with. So again, we have a consent for this that we would like for you to fill out now. The other, next one is the hepatitis C antibody positive donor into a hepatitis C patient that it needs a liver transplant because they have hepatitis C induced cirrhosis. This sounds kind of counterintuitive at first, but I'll explain the situation. Hepatitis C is a very slow virus, and it takes 30 or 40 years for it to actually produce severe liver disease in a patient, and at least 20 years probably before it develops any amount of scarring in the liver. So basically there is probably a group of young people that have been exposed to hepatitis C. They have an antibody that is positive, and they have replicating virus. Their livers look normal, they act normal, and they could be transplanted into someone who already has hepatitis C. This obviously doesn't get rid of the virus, and the patient who gets it has already got the virus. But really about 7 or 8 years ago, there's a new set of drugs that will basically cure all people with hepatitis C. So the patients that already have the virus before transplant, they can take these medications that they take for about 12 weeks after transplant, and about 97% of the patients will be free of the virus, depending, even if they get a virus negative organ or one that has hepatitis C antibody positive. Some people with hepatitis C antibody have kicked out the virus. It's a fairly small percentage, and those people don't have hepatitis C and will not have any liver disease. And so those donors make sense to also use those donors in this particular situation, and may receive treatment if the virus starts will receive treatment afterward for the hepatitis C. virus that's already in the recipient. So we think that this is a resource of patients. Probably we think about 3% of the U.S. population has hepatitis C circulating. Obviously, people that already have liver disease from that, we don't want to use those donors, but we could use the ones that are basically newly infected. Again, we'd like you to sign a consent for this now so that we don't have to sign you up right before the transplant, which I think is kind of under duress for our transplant candidates. The next is the use of fatty livers. As you know, the population of the United States is getting heavier and heavier, and with that, the organs that we remove have a little bit more fat in them, seems like every year. Just a little tiny bit of fat that infiltrates the liver doesn't affect the preservation of the organ or how it will work long term. When you get up to around 30 or 40% of the cross-sectional area of the liver being fat and not being just regular liver cells, then the chance that the liver will not preserve well go up pretty sharply, and it increases the chance that the liver will not work at all and put you into an emergency situation where you would be with the liver not working, had to be retransplanted quickly. Also, with fatty livers, the patients are more jaundiced and they have what's called poor function for a while. The blood doesn't clot as much, and they sometimes have to have more bleeding after the operation. Also, maybe more problems with low blood pressure during the operation, during the reperfusion. After the blood that you have flows through the liver, the stuff that comes out of the liver can make you sick for a while. So these fatty livers we use, and we won't be signing a consent for this. This is kind of a judgment call on our part in consultation with you and other doctors in their use. But I'm just discussing that we will try our best to transplant you with organs that really we think are going to work and to get you out of this bad situation of end-stage liver disease with multiple complications. The next type of donor is a little bit more complicated, and I'll kind of discuss it at length. This is, as I talked about, the donation after a cardiac death. As I said before, most donors have been in, let's say, in a car accident, their brain has been destroyed, another doctor has pronounced them dead, but their heart is still beating. And the different organ teams can show up while they're being perfused with the blood that's being circulated by the heart, and we can dissect out the different organs, and at the last minute we clamp the main blood vessel coming out of the heart, the aorta, and then we perfuse all the organs, the heart, lungs, kidneys, pancreas, liver, and we can perfuse them immediately, and that will preserve them for many hours in a very safe manner. Fortunately, we have very good preservation solutions. And this is how we do probably around 95 to 90% of our donors. And the results of that are well known and excellent. There is a group of possible donors that are different. These are people that maybe were in a car accident and have severe brain damage such that only just the very lower parts of the brain as related to breathing are still working. They are not technically brain dead, but the patient's family has decided that they are basically want to remove any kind of life support because there is no chance of the patient waking up. And when that happens, the organs can be removed, but only after the heart is stopped for about 3 to 5 minutes. And so what's often done is the patient is transported to the operating room, and a whole set of doctors that not related to the transplant service, they take the patient off the ventilator, and sometimes, and also any other life support, and sometimes the heart will stop within just a few minutes, and then the next 3 minutes or 5 minutes is counted, and the organs are still not being perfused with blood, and then they're pronounced dead, and then we come in and quickly perfuse the organs and remove them. If under just the right circumstances, those organs work just fine for organ transplantation. Um, Again, they have a higher chance of what they call primary non-function, again, that is not working at all. It jumps from about 2% to maybe 6 to 8% chance that the organs will not work at all and you would require an emergency retransplantation. Of course, the allocation system is designed to retransplant those people before anyone else. And the few times that we have had primary non-function, in general, we've been able to find a new organ, but it's not guaranteed. And so that's one of the main risks at using these type of donors. Again, if the blood pressure slowly goes down and the heart doesn't stop beating for a long period of time, the organs undergo irreversible damage, and they're really not useful for liver transplantation or other forms of transplantation. Also, it is appropriate to know that using these type of organs in somebody who is already has a very high MEL score, very ill, and because the organ won't work quite as well at first, that those patients probably aren't appropriate for this type of receiving this type of organ. And so we recommend that people that are interested in this have what they call a lower MEL score, not have any significant previous operations. The vein running out of the intestines that runs in the liver, the portal vein needs to be open because that can slow us down in doing the recipient operation. So we can go over to see if you really fit into a category of patients this would be appropriate. In some sense, you don't have to wait until you're really sick to get an organ for liver transplantation. This allows you to, in a sense, jump the click, but at the same time, there's more chances of complications. And one of the most insidious and probably to us the worst complication is that during this time when there's no blood flow to the liver cells can jump back and regrow themselves very quickly. But the bile duct cells, the ones that handle the bile and get it into your intestines, they seem to be especially prone to injury. This injury doesn't show up for a couple of months, but then at that point, the bile duct starts causing strictures and tight spots, and basically produces a series of infections that we sometimes are not able to control. When this happens, it's a fairly miserable situation, and we can try different techniques to kind of keep the bile ducts open, but often retransplantation is required. It's very rare in regular donation, not DCD, maybe about 2%. Probably jumps up to more to 8 to 10%. Much lower in some people's hands, but it's definitely an increased risk, and when it happens, it's very difficult to control. So again, a chance to be transplanted when you're not quite as sick, but also would give you, but then some increased risk for this significant complication. Again, we would like you to sign up for this now, and if you think that this is something you'd be interested in, we have ways for you to sign up after you leave here also. And also we're available to answer any of your questions. The last is what's called a quote high-risk donor. Again, we do not plan on using any donors that we think are truly at risk to transmit HIV, hepatitis B, or hepatitis C, or any other virus or bug. On the other hand, we have excellent tests that pick up minute amounts of the virus, and so just as we use in blood banking. And so, but occasionally there is a short window of time when someone could be infected and then die for whatever reason, and the test would not pick up this virus. And it's usually just a few days, maybe even a few weeks. And the allocation system, UNOS, understands that, and there can be situations where the patient is kind of high risk to have one of these viruses. These are people that maybe had been in prison in the last year, um, people that use IV drugs. There's actually 10 things that could be thought to make that person at high risk. The tests are all negative for these viruses, very sensitive tests, but because they're high risk, we need to inform you that the tests are not perfect. To date, we have not had anybody infected in our program, and it is very rare across the country that these tests are negative for the virus, and it turns out there's actually virus in the organ. Um, we think that the chance of having one of those viruses is low, and the chance to transplant you and save you from these life-threatening symptoms outweigh this very tiny risk. Um, we think that for instance, like hepatitis C has a very short window. If the test is negative, the chance of you get it may be around 1 in 10,000. HIV probably around the same. So it's a very rare chance. There may even be less chance of you actually being transmitted with the virus. This won't come up at all if the tests are negative and the patient has no risk factors for these particular situations. We again would like to sign up beforehand. Some programs kind of wait to the last minute and try to sign you up kind of the night of the transplant, which I think is, again, under duress. You want to talk with your family, you want to think about it. But I think consenting for this, I think is low risk for you and puts us all in the driver's seat to try to take care of you. Also, there's a situation where a patient's in a trauma situation where they've lost a lot of blood and they're probably all their blood has been replaced from someone else's blood. Then the tests are not as helpful in any situation. And then again, we would sign you up for the same kind of situation. So we're available to answer any of your questions. Most of these are kind of straightforward decisions. You can always opt out at the last second, or a week later say, I signed that, but I just don't want to do it. You're not held to this. And also, if you want to sign up later, that's also. I will say that people who don't sign up now probably never will. They just got other interests and they're sick and so forth. So we would like to have our best chance to transplant you.